Hi, I'm Emily Lee. I'm a third-year med student at MSU Com. So we have a 21-year-old African-American gentleman with past medical history of migraines without aura and hypertension with a BMI of 28.2 who presents to the ED for intractable headaches for 5 days with nausea and non-bloody emesis for 2 days, presyncope that occurred earlier today. His headache began insidiously and progressively worsened to 10 out of 10 pain, causing him to come overnight to the ED. States that the pain is localized to the bifrontal and retroorbital regions. It's constant pressure-like pain. Says that this feels a lot different than his usual migraines, which are normally alleviated with Excedrin and sleep. And yesterday, he was actually seen at a different emergency department for headache as well. They gave him IV Toradol, Compazine, and Benadryl and discharged him, but his headache came back after. He endorses a loss of smell that began about a year ago during the COVID-19 pandemic, and it's still going on. He denies any associated lacrimation, rhinitis, photo or phonophobia, visual changes, fever, chills, abdominal pain, chest pain, dyspnea, vertigo, palpitations, weakness, or ataxia. And he has not had any sick contacts, trauma, or drug or alcohol use. And on chart review, you do note that he has an extensive emergency department visit history for similar headache complaints since he was 10 years old. And the most recent head CT that you can see was when he was 15 years old. That was 5 years ago, and it was unremarkable. Past medical history, other than what was noted, he does have chronic sinusitis and allergic rhinitis, no surgical history, no allergies. Takes amlodipine, 5 milligrams for the hypertension, Excedrin migraine as needed. Family history is notable for brain aneurysm and his uncle and his grandfather. And he does smoke marijuana occasionally, but no other drug or alcohol use. So objectively, vital signs, he is hemodynamically stable. No tachypnea. He's a little bit, his blood pressure is a little bit high, but he's sitting at 96% on room air, and he's afebrile. Physical exam is normal, and labs, it's notable for a 6.3 potassium, but that was hemolyzed. He does have an elevated white blood cell count of 14.2, elevated D-dimer of 2.01, negative COVID, negative HIV, antibody and antigen test. So we're just based off of his history alone, we're going to go ahead and scan his head because everything else is normal, but then it's just concerning that this guy keeps coming in for the same complaint over and over but doesn't get a head scan. So on the head CT, you do see some sort of frontal mass, and it's difficult to appreciate because it's a head CT. So we're going to go ahead and order an MRI, but before that, we do see a read that it is a 6-centimeter lesion in the frontal lobe, and there is a mass effect with midline shifts. So we're going to go ahead and consult neurosurgery on this guy. MRI comes back, and it is pretty obvious that he has a right frontal mass lesion with involved with midline shifts. So our differentials for the headache is primary versus secondary headache. And so the primary headache, just a reminder, is the pound mnemonic, pulsating, 1 day duration, unilateral, nausea, vomiting, and disabling, such as causing somebody to go to sleep. And that's what normally his migraines are, but today this headache is different. And so a mnemonic for secondary headaches is Snoop 4, and you can read that on your own, but there's a picture of Snoop Dogg, so you can remember. And so the differential for that is intracranial infections like meningitis or encephalitis, intracranial hemorrhage, intracranial space occupying mass lesions, pseudotumor cerebri, and the list goes on and on. So what is the final diagnosis on our guy? It turns out that it was a high-grade glioma, and interestingly, during the craniotomy, it was adherent to the olfactory nerve, but the surgeon was able to dissect it away. And so the final path report showed that it was a glioblastoma with a WHO grade 4, and it was more typical of an adult-type glioblastoma as opposed to a pediatric type, even though this guy was 21 years old. And a couple facts about GBM is that it's very fast-growing, it's incredibly aggressive and malignant in adults, where people die as early as 6 months if it's left untreated. And so the median age of diagnosis is 64, with men greater than women. And it's interesting because our patient was only 21 years old, so he was very young for this adult type glioblastoma. And so Fortunately, during the surgery, it was successful. He was discharged in stable condition with no focal neurologic deficits, and he was referred to Carmanos Cancer Institute and recommended for clinical trials. However, despite surgical resection, it is a poor prognosis with only a 40% survival rate in the first year after diagnosis and a 17% survival rate in the second year after diagnosis. So, really young guy. Somebody with anosmia, headaches, intractable, nausea, vomiting, don't push it off as COVID-19. Definitely broaden your differential. Think about secondary headaches, space occupying lesions, like our gentleman here. And that was my case. Thanks so much for watching. Here are my references.